So the next session is focusing on AHPs and Advanced Practice. So this morning was more of an introduction to allied health and looking at preceptorship, and we're now moving forward into how you can develop your career from where you start off as an early careers professional. Carrie, you've had a lot of work in preparing this. What would you like to sort of say to introduce this going forward?
Thank you, George. So we've got a wonderful panel lined up for you that come from the north and east in terms of our hosts. So Claire Arditto is our regional head up in the northeast, and she leads nationally for the AHP and the Enhanced Practice space. I'm delighted that we're welcoming back Luke Cunningham, who's a AHP from Cornwall like myself. He was here last year on a leadership panel, and he's coming back to discuss and describe some lived experience and some ideas around what enhanced practice and enhanced practice development will look like for people, along with some other great panel guests that are coming for their first time. So it's wonderful that we get people returning as our AHP career ambassadors, and that we get to welcome new folks in each year as well. So they will talk about the enhanced practice apprenticeship route specifically. So this is a new and exciting opportunity where people will be able to be released from the work and the roles that they're in, to be able to learn while they earn, to progress with their career. So it's a slightly different take on development in using apprenticeships within careers, as opposed to what people are more used to doing, which is kind of CPD, where you would go off and do a module in something or a course in something else that takes you away from your work. This learning is integrated into your work when you do it via an apprenticeship route. So it's to give people an opportunity of what's out there, what will be coming, and how this may be another option for them to grow and develop their skills when they're kind of in their middle, heading towards advanced practice in that space. Fantastic.
And it goes without saying, as we said earlier, you know, these sessions are interactive to a degree. Do let us know in the chat section what profession you're from and what your professional background is, and where you are in your career, because it's really interesting for us to gauge who's listening and watching in, and certainly so we can carry on that message after the conference. We really want to get the conversation going. So myself and Carrie will disappear in the next couple of minutes. Do keep sharing on social media with #HealthCareersLive, and the session will begin shortly.
And welcome to this Allied Health Professions Enhanced Practice Careers webinar. My name's Claire Arditto. I'm the Regional Head of Allied Health Professions in the North East and Yorkshire, and we're really pleased to be presenting this session to you today. The aim of the session is to share with you the current opportunities within enhanced practice, to describe the enhanced level of practice, and to provide information on the enhanced clinical practice apprenticeship. We're also going to update you on current plans for training and education specific to the AHP professions. And I'm really delighted to hear from a number of fantastic clinicians working at an enhanced practice level, to hear of their journey and experiences of developing within their roles. And then finally, we'll have a panel question and answer session. So I'm going to let the panel introduce themselves now.
Thank you, Claire. Thank you for having me this morning. My name is Fay Lane. I am Apprenticeship Relationship Manager working within our National Talent for Care team, covering all things about apprenticeships. So thank you for having me this morning.
Hi, Claire. Thanks for inviting me as well, Claire. My name's Sam. I'm a clinical specialist stroke dietitian with extended roles at Bradford Royal Infirmary.
Hello everyone, my name is Cris Mulshaw and I'm one of the programme managers in Health Education England and supporting Claire in this national piece of work.
Hello everyone, my name is Johnston. I'm a critical care and trauma dietitian at Salford Royal, part of the Northern Care Alliance.
Hi everyone, my name is Amy Dixon. I'm a diagnostic radiographer working in Leeds, undertaking enhanced practice in urology procedures.
Thanks everyone, great to hear from you. I'm going to introduce Fay and Cris now, and they're going to talk to us about the Enhanced Clinical Practice Apprenticeship.
Thank you, Claire. I believe I'm sharing my screen, so I'll just do that quickly. You can all see that now. There we are. So I wouldn't introduce myself again because I've just done that, but really wanted to talk to you a little bit around the Enhanced Clinical Practitioner Apprenticeship and basically the roots for where it's come from. So with no further ado, just to give you some of that background, very much the apprenticeship was based on some work by Alison Leary back in 2019, who completed a piece of work to essentially define what enhanced practice is and how that exists within our workforce. And a lot of that work was then used by the Apprenticeship Trailblazer Group to develop that apprenticeship standard. So it's very much based on that. Now, when we talk about it, and especially this was defined by Alison's work as well, we are talking about a level of practice within the healthcare workforce that's delivered by experienced registered professionals, normally with first level statutory registration or a voluntary registration as well, who undertake complex work and manage day-to-day risk. We understand that enhanced practice across multiple settings, that those acting at that level of practice as well have many job titles and many roles. It's not nursing specific, it's not AHP specific, it's truly multi-professional. But also that whilst working across those different spheres of practice, they often have skill sets that are related individually to their own practice, so maybe physio OT or something like that. So that is kind of in a nutshell how we would encompass what enhanced practice is. But when we look at the apprenticeship, as I was saying, that was based upon that work, defining what enhanced practice is. Now, the apprenticeship doesn't seek to replace any existing educational pathways. We know that people get to this level of practice through various different routes and educational pathways. People maybe achieved enhanced practice through CPD, postgraduate diplomas, certificates and such. But the apprenticeship is an alternative. It's an additional route to that enhanced level of practice and training. So it's very much probably to staff who are kind of post-qualification, post-registration, who are starting to move into their first kind of complex roles that require them to have more complex knowledge and expertise. So that's very much where we see the apprenticeship sitting. And I think now I'm handing over to Cris for a bit more context. I'll stop sharing my screen.
Yeah, thanks, Faye. And so I was just going to update you really in terms of where the apprenticeships are in terms of the national development, and following the apprenticeship standards that have now been published, some of the universities have already started to implement apprenticeships, and they're very multi-professional in direction. So you'd be working with all sorts of other professions on that apprenticeship and defining your own learning and professional development within those contexts. Within that context, and as an example, one of the universities is doing an apprenticeship in frailty. So that would be one potential avenue for you to follow if this is the educational route for you. But also HE are really keen to ensure that the HEIs offer some profession-specific modules at this level too, and we've just started a process to commission this. The intention will be to ensure the profession-specific clinical development at this level for many of the AHP professions. And I think that's it.
Thank you, Cris. I'm going to hand over to our professional colleagues now, who are going to share with us their insights of working within the enhanced practice space. And we'll start with Sam and Phil.
Hi, thanks, Claire. Phil and I have put a few slides together, but it will mainly be a sort of conversational, just a bit of an update about who we are, how we've got to where we are, and how that might link in with the apprenticeship and enhanced practice plans. So I'll just share some slides as well, if I can find them. Well, they're not open, so that's always a good start. Bear with me 1 second. There we go. As you said earlier, I'm used to using Teams, so I didn't realise it had to be open. So, files. Struggling to share this for some reason.
Ever the high tech. Let's see if I can find it as well.
Yeah. PowerPoint as virtual background. Give that a go. Oh, look at this.
Yeah, that's working.
Wow, my face is in the corner of that as well, which is a bit scary, isn't it, for everyone? Okay. So yeah, thanks for that. Yeah, I'm Sam, as I've said before. I'm a clinical specialist, extended roles dietitian in stroke, and I've also recently started contributing to some of the NG safety research within our trust as well, off the back of this sort of the job that I do now and some of the experience that I've gained as working as an extended roles dietitian. So I'll let Phil introduce himself as well now.
Yeah, so as I said before, I'm currently working within the critical care and trauma teams at Salford Royal, and as I'm soon to be starting a secondment as the dietetic manager as well here at Salford Royal in the job share role.
Ace, cheers, Phil. There's a couple of pictures there of myself and Phil in action, which as anyone that knows dietitians would know that it's not a usual sort of part of our roles. This is something that we've developed into. So just a little bit of a background. So I'd pulled some bit of information together about why we looked at extending the role of dietitians and in our trust. And I've also spoke to Phil about this previously as well. So we got sort of really passionate in thinking that dietitians were best placed to input in every step of a patient's nutritional journey. We kind of asked ourselves a question. So how can dietitians help the nursing and medical teams? Also looking at getting the best sort of treatment outcomes for our patients. We looked at documents like the AHPs into action, as well as sort of Royal College of Physicians and NICE guidelines, and some of the clinical skills related to nutrition that myself and Phil have upskilled in our nasogastric tube insertion, nasal bridle or nasal retention device insertion, confirmation of X-ray position, so nasogastric tube position, whether that's bedside or chest X-ray, administering feeds where needed, looking after those tubes, doing some initial swallow screening, and possibly looking into sort of prescribing. So a little bit of sort of my background and story. So I've qualified as a dietitian 4 years ago. Started very quickly as sort of a band 5 newly qualified as part of a general caseload on the acute stroke unit. And at that point, I was kind of, let's say, alarmed at some of the sort of practice that went on with regards to how timely we placed NG tubes, how timely we reinserted them, and then some of the enteral feeding practice on the ward. So it's kind of my interest perked up quite quickly with regards to how can we optimize treatment outcomes and patient experience with regards to enterally fed acute stroke patients. We kind of did a business case and it was unfortunately unsuccessful. As time sort of passed, there was some money that was released due to some bed closures from the nursing budget. So myself and my manager, the stroke general managers and nursing managers sort of met and decided, sort of had a look at how could we extend or broaden the role of an acute dietitian to best deliver and fill some of these gaps that had been identified in care. So we kind of put some scoping plans in place, as well as to find some information, and went to our advancing practice panel locally to extend the role to include some of the clinical skills that we've included before. And sort of 3 years down the line now, it's gone from being a band 5 to then a band 6 job to then being upgraded to a band 7, sort of subject to meeting competencies and developing a local competency framework. So it'd be nice with the rollout of a portfolio or an apprenticeship style enhanced clinical practitioner sort of course, if we could try and standardize some of this approach across trusts and also sort of intra and inter trust nationally. What I would say is it's really opened the door for me with regards to how much I can do for a patient. So from the minute they sort of come in on an acute stroke unit, I could do a swallow screen for them. I could suggest an NG tube insertion. I could do the NG tube insertion and start a feed. So we went from patients being delayed starting enteral feeding up to 72 hours to being able to do it within 4 hours of admission onto our acute stroke unit, which is a massive difference for quality of life and also treatment outcomes, as we know that malnutrition is really prevalent post-stroke and can have some really significant impacts on patients' sort of rehab outcomes and treatment outcomes, as well as sort of the autonomy and upskilling for myself. It's really allowed me to work closer with the wider MDT, do some more training with medical members of staff, nursing, other AHPs, and more recently we're developing researching into confirming nasogastric tube position via some local research that they kind of ultimately approached me as somebody that was a specialist in that area and asked me to get on board with their project. So it's kind of just opened a lot of doors for me. It made me feel much more autonomous and skilled as a practitioner. And it's certainly something that I would recommend if anybody was interested in looking at extending, enhancing, upskilling, and, you know, whichever sort of descriptor you want to use for my development in my career so far. So that's kind of my story. Happy to pass on to Phil to share his experiences.
Hello again. So if I start back at the beginning, so the whole reason I got into dietetics was that my sister was diagnosed with anorexia at a young age. So I was very aware of the impact of dietetics. As part of my sister's treatment, she ended up with an NG tube for a period of time. And so I was instantly fascinated by this, like, how is she getting fed by this magic tube that's in her nose? So I qualified in 2015. Again, similar to Sam, had a band 5 job, quite quickly moved on to a band 6 job within a renal specialty. And again, one of the things I mainly noticed in a lot of our nutrition support patients was, in my opinion, unnecessary delays in feed. It's an incredibly busy ward where patients do need that support. And one of the things we were regularly recommending was NG tubes, but due to just skilling on the ward and skill mix available, or just basic time on the ward, patients weren't getting NGs in a timely manner, or it would be delayed unnecessarily. And I just thought there was a clear gap here for dietitians to be able to place and to action on our plans. I raised this many times, and it was always kind of bounced back to me of, oh, that's not our role. Oh, we've got nurses for that. Oh, we've got doctors for that. It's out of our skill mix. Why do we want to take on that risk? Maybe you're just a frustrated medic. And all of these things I found incredibly confusing as the nutrition professionals, yet we weren't taking on any of that ownership. And that was a big bugbear of mine for quite a long period of time, regardless how many times I brought it up. With relocating, I moved to Salford in February of last year, and again, it was one of the things I was always very passionate about in my interview when coming over to Salford, and it's been supported in that time. So since then, I say I've done nasal bridle training, I do swallow screens and within critical care, and also now placing NGs. Sam's been a massive help in this, and he's pretty much kind of pioneered the pathway for dietetics to be doing this, because in my opinion, a lot of the roadblocks in the way of dietetics getting to these skills has been dietetics. We seem to be stuck in that that pathway of we're responsible for what goes down the tube rather than have anything to do with that tube, and it can be a lifeline for some of our patients, and it can be an immense source of distress for some of our patients. A few years back, I was fortunate enough to have an NG placement as part of Nutrition and Hydration Week, with a journal of that week published on the British Dietetic Association's website. And I felt like really gave me a good understanding of what our patients go through and how important and how daunting having that NG can be. So as part of my role now, when our patients are obviously coming to us up very unwell, and once they're extubated or at a stage where they can have a swallow screen performed, we can assess that swallow. So we can either get them eating and drinking quicker, or if they fail that swallow, we can then get an NG tube in and then start to commence feeding very quickly. And we had an example of this just in the last few weeks of an elderly confused chap who we swallow screened, sadly failed to swallow screened, and he had an NG and was getting fed within the hour. Whereas without these enhanced role skills, we had no nurses on shift who could have done the swallow screening, and the chances are he would have ended up waiting the next day. And then maybe if someone hadn't have action that, he might have waited even longer to have that swallow screen and then start his feeding. when we know how important feeding is in our patient's journey, and how important it is moving them through their rehabilitation process as well. I think it's really highlighted the importance of the dietitian amongst the MDT, and I think the consultants, the consultancy team, the medical team, and the nursing teams have all been incredibly on board with this, and all very supportive of it, because I'm sure, as anyone who works in the NHS knows, we are an incredibly busy service, and I think working as that team is so important. If we can see areas where we can help our nursing colleagues, our medical colleagues, then where appropriate, we should be taking all the opportunities we can to help that, and have a very well-structured and well-formed team where we can almost have that cross-cover of some roles that we ensure a really high quality level of patient care.
Yeah, thanks for sharing, Phil. It's, I think there's two examples there of a similar approach to enhancing our practice as a dietitian in two quite different areas, trauma and critical care, and also acute stroke care, both of which I think have really enabled us to become more autonomous, effective practitioners, and ultimately higher valued member of an MDT, and
definitely
providing much higher level of patient care. From what I'm hearing.
I would agree entirely, and I think previously, I think sometimes if we recommend an NG and then we take that step back and walk away, sometimes I feel amongst the nursing staff they can always feel that element of passing the buck of, oh well, you've told the patient this is going to happen, but as I say, it's not a pleasant experience to go through from a passing or a pass I don't know if that's the right word at all, point of view. It's not something many patients want to go through. And if you've built that relationship with them and you can talk them through why we're doing this and the benefit of that, then I've already found that patients are much more reassured by that, rather than then passing them over to someone completely different to then go through that process.
Yeah, absolutely. And I think, we don't do anything in life if we don't truly understand it. So if you've got the right person to explain, the reason you're doing something and how that can be of benefit, then you're more likely to be on board with that treatment, especially as you say, Phil. I think they're very uncomfortable to have put in, and they're very uncomfortable to have in once the initial placement's done for a lot of patients anyway. So if there's a better level of understanding because we've been able to provide that expertise and that education to the patient, then you're likely to get better sort of buy-in to treatment, so to speak.
Yeah, and I think just tied in with that as well, again, I think dietetics has almost tried to set itself really high standards of trying to maintain competence. Like if we look at maybe the nursing levels, say, and medical levels, it's see one, do one, teach one. And again, when I was mentioning some of this previously, I was told, oh, well, to maintain competence, we need to be placing 10 NG tubes a week. I mean, I know nurses who probably don't place 10 NGs within a year, but yeah, they would be able to go about their daily business. But again, us as the nutrition professionals would be held back from that. And similarly, because we work with NG tubes, we work with bridles so frequently, we're very aware of what the process is. So there are times when I've been talking through the medical team or nursing staff of the steps they should take, because they've been allowed to do that, but we've been held back. But yet we're able to comment and commentate on how these procedures should be done, and it was just mind-boggling for me.
Yeah. Likewise, just before I move on to the summary, I think I've had medics come up to me and say a patient needs a nasal retention device, a bridle. They've never done one before, but they'll give it a bash. And they're quite complicated and extremely uncomfortable procedures for a patient to go through. And my immediate response is, these aren't things we should be giving a bash just for your CPD. I think it needs to be really understood what the patient is going through here, which having someone like myself and Phil to be able to step in at that point and provide education and say, actually, do you want to do one with me, shadow, see how it goes? I can then have a look at how you do it next time, etc. I think is really important. So I guess sorry, Phil.
I was going to say, and it's that level of expertise and that troubleshooting and just very simple things in terms of like where you position yourself around the patient's bed, how you get that bridle into place, just manipulating the tube. And these make massive difference to the patient for, as Sam said, an incredibly uncomfortable procedure.
Yeah, absolutely. I think just to summarize, I guess I'm conscious I could talk about this all day. I could by the sound of things. But I think we're a key AHP essentially, and I think there's been times where it's felt that dietitians are an optional extra, whereas I don't believe that at all. I think we are a key AHP, and having a dedicated extended roles or enhanced clinical specialist dietitian, we can lead change, further develop skills of our workforce, both individually and also for the wider MDT, looking at deliver evidence-based practice and essentially providing dietary intervention for more patients, more timely, have a positive impact on their experience, reduce costs, save medical and nursing time, ultimately optimize patient treatment outcomes, and provide a source of expertise, education and learning for other MDTs and other dietitians, which I think is what Phil's sort of talking about as well. It sounds like myself and Phil are extremely well aligned on this, having never actually met each other face to face, which is lovely. So if everyone's happy with that, then we can move on to whoever's next to present, and I'll stop sharing my screen. And
Sam and Phil, thank you so much for sharing your insights, and I'm sure that's going to foster lots of thoughts and ideas in those colleagues joining us on the call today. So I'm going to hand over to Amy now to share with us her experiences.
Right, I'll just try share. Okay, so not many people know what fluoroscopy is. So it uses X-rays to see the movement of body structures. So in our trust, there's a well-established pathway for radiographers to do enhanced practice on procedures of the gastrointestinal tract, but there'd never been anyone who focused on urology procedures in Leeds. We're quite a big urology unit, so we have a lot of patients. So we got a new consultant appointed who kind of saw that opportunity that a radiographer could start to do it. So in 2015, I became the first radiographer to start undertaking these procedures. So all our examinations focus on kidneys, ureter, bladder and urethra of the patient. So they might have had operations for tumours removing, bits of the kidney removed, and we do procedures afterwards to check if they've got any leaks before they can get their catheters removed. We also have, the main work is patients with nephrostomies, so tubes into the kidneys to help them drain, which is prolonging the life of their kidney and meaning they don't need transplants. We change these tubes for patients roughly every 12 weeks. So to start off with, the training was all in-house and it was done by one consultant radiologist. And I had a logbook to fill in, and I documented all my observed directly and indirectly supervised examinations, and then reflected on the cases. And then I'd sit down with the radiologist and go through the procedures afterwards. The number of supervised examinations was dependent on how complex the examination was. So at the start, I was only doing procedures focusing on the urethra and the bladder, and then as time went on I started doing more interventional procedures, so they obviously had more supervised cases that I had to get documented. Once the logbooks were completed, they'd get signed off by the radiologist and we'd get letter of authorization. But one bit that was frustrating is, as enhanced practitioners, we're not allowed to formally report on our examinations. So we just do a provisional comment onto our computer system, which the radiologist would then sit, review our images, look at our comments, and they would be the ones who issued the formal report in the end. The service is now developed and there's 3 radiographers on board. We have 2 sessions a week, regularly have registrars that we're training to do these procedures. And we liaise with the other departments, so to make it as streamlined for the patients as possible, we do their examination, post-op examinations on the same day as they can get the catheters removed. So as soon as they've gone to us, we issue them with an informal report that they take to the department and get the catheters taken out if they've not got any leaks. So we're saving that time with patients having to get readmitted or reattend hospitals for other procedures. I said before that our main workload is with nephrostomy patients. So we offer a service where patients can ring us between 8 AM and 5 PM, Monday to Friday, if they're having issues with the nephrostomy tubes. So if you think if someone's got a tube hanging out of the side, they're quite high risk for getting them pulled out. So if they get pulled out of the kidney, there's quite a small window of time in which they can get that tube might heal up the tract to the kidney, they might lose it, and then they'd have to have the tube put in from the start, which is quite an invasive procedure with new holes being punctured to the kidney. Whereas if we can get in there and get access back to the kidney, we're stopping them having to be readmitted to the hospital. So our aim is that we usually try to see the patient the same day or the next day and try save that nephrostomy tube in the kidney to continue their drainage. So benefits to the patient and the surface. So with there now being 3 radiographers who do this, we've managed to increase our capacity because we don't have to rely on radiologist availability to do these examinations. We've gone from having 1 list to 2, so it's obviously reduced our waiting list. And another thing we have to factor in is a lot of our patients have to have their procedures done in a certain time frame. So the nephrostomy patients in general are seen every 12 weeks, but if they start experiencing the tubes blocking regularly, we'd bring those forward to 10 weeks, 8 weeks, 6 weeks. So those patients need to be seen at those intervals. So now having 2 lists a week, it gives us a bit more freedom with the other patients who are time dependent. Our list, because we have minimal radiologist support now, has allowed the radiologist to be freed up to do the more complex work in vascular or interventional. It's also a cost-effective method, obviously because we're cheaper than consultants, and the main thing of avoiding the admissions. So if we didn't offer the service during the week, patients would have to attend A&E with their tubes not working. So they might have a 10-hour wait in A&E, then wait to be admitted to a ward. Then you have to wait for someone on the ward to see them, to then recognise that the tube might be blocked or displaced, then put a request into us. Sometimes patients can be waiting 48 hours before they've even had a request put through for someone to have a look at their tube. So by them just being able to ring us directly, it saves all that. Like sometimes we can say, right, come now, and we're seeing them within half an hour. It's also increased patient satisfaction because they like seeing the same staff all the time, so they know that they can just ask for the 3 of us by name. We can have a chat with them and we're there for any issues. Even if they don't end up coming into us, sometimes they're just grateful to have talked through the issue that they're having with the tube. So then the benefits to me, so since I've taken on this role, it's definitely increased my job satisfaction. In general X-ray, you don't often see patients for very long. Like a chest X-ray, they might be in the room for 5 minutes at the most. You don't get to have long conversations or build up much of a rapport with your patient. So seeing these patients regularly, it's really nice, and we know the ones that bring us chocolates and things now. So that bit's really nice. And I've also enjoyed getting more involved in the patient pathway, so getting a bit more of an understanding of why someone might have nephrostomy and watching them initially put in from the start, so that when they come to us for them exchanging, I've got more of that knowledge that I can discuss with them any issues, because it tends to be that they get the nephrostomy put in the hospital, they've got this tube in the kidney, they don't really know much about it, and they get sent home, and all they know is that they're coming back to us in 12 weeks for it changing. And in that time, they'll have had quite a lot of questions building up. So me and my colleagues have created what we call a nephrostomy passport that'll go home with the patient, and it should answer all the questions, and it gives them all our phone number, advice on what to do. It's got pictures of what everything should look like, and they've really benefited from having that information in that interim between having the tube put in and then coming back to us for exchanging. Like Sam and Phil said, it's nice to have the recognition within the MDT and building up that rapport with the urology consultants and the specialist nurses. So I've done some presentations for the specialist nurses, because they're the ones who are requesting these examinations. I could go through what the examination actually involves, so when they're requesting it on the ward, they understand what the patient's going to have done, so they can pass that on to the patient, so the patient's more aware, rather than just being told you're going for this test and then not having a full understanding of what's going to happen. I've also done non-medical referrer training, so that means that I can request the x-rays for our follow-up nephrostomy patients. And again, that came about because we found that if we relied on the doctors or the consultants to always submit the request after an exchange, they were getting lost in the system, and patients were going months without having the tubes changed, and obviously increasing like the risk of infection. So now, as soon as we've changed the patient's tube, we do our provisional comment, and then we submit a request ready for them for next time, so that there's that safety net, knowing that they shouldn't fall through the cracks of the system, and they kind of have an idea of when they're next coming back. So along the way, there has been some challenges. So because it's not been a recognised pathway, it does feel like it's taken quite a while to get to where I am now, because we've had to create new logbooks, new schemes of work, and everything has to get signed off by management. But for the other two radiographers, because they've only been doing it within the last 3 years, they've managed to progress through quicker, because obviously everything's already, all the documentation's already there. And when we're doing the x-rays, we use x-ray dye to obviously see the structure in the body, and that means we have to work to patient group directives, so we have to follow very strict protocols for the examinations, and sometimes you can feel quite restricted by them. So at the minute, there's a worldwide shortage of the x-ray dye. We can only get one certain strength, and as radiographers, we're not allowed to dilute it. So for those examinations where we would need it diluting, the consultants are having to come in to inject the contrast. So there's work going on in the background to get our PGDs updated so that we can dilute that, because that's having a massive impact at the minute. And another little challenge is the radiologists are confident in what they do, but then they expect us to kind of be on standby all the time to do the procedures. But we still have to work in the department, going to theatre, x-raying people on the ward. So sometimes we have to say to them, like, we're not available, you'll have to do it today. So then what's next? So I've just undertaken a postgraduate certificate at Bradford University so that I can do the formal reports of my examinations. So I won't need any radiologist input from that aspect then. I'd still, if we've got a difficult patient and we're struggling to get back in the kidney, we might always ring them or get them to come in to give us a hand. But the hope is that because I'm working towards recognition as an advanced practitioner, I'll then be able to do the complete examination myself, the formal report, refer them on for the next time. And then I've just started working in lithotripsy as well. So that uses shock waves to break down kidney stones. And in that part, we are learning how to do ultrasound. So the hope is that that will then lead us on to be able to learn how to do other procedures as well that involve the ultrasound, because we don't get trained that as general radiographers, it's something else you have to do. So I'm looking forward to that bit. And we're also wanting to increase our capacity, so we have 3 lists a week, because our waiting lists have just are ridiculous because of COVID. With the backlog, patients couldn't go to theatre to have kidney stones removed, so they'd get a nephrostomy put in. So our workload of having to have those patients, have them changed, has probably tripled in the last couple of years. So we're struggling a bit with 2 lists. So yeah, work's ongoing to try and get at least another half session for the week. And that is it. Thank you.
Amy, thank you so much. And it's really fantastic to hear from such highly motivated clinical colleagues who've taken their own initiative to develop the career pathway. You know, especially when there hasn't necessarily been a recognised pathway to develop within this enhanced practice field. So thanks so much for sharing that with us. What we're going to do now is just ask a few questions to the panel, which I hope for those of you watching today will really sort of give you a little bit more information. And one of those things that I think is probably going to be really important to cover is what Amy mentioned in terms of the progression of her career towards an advanced practitioner. And I'm just going to ask Cris to describe to us the difference between enhanced and advanced practice.
Thanks, Claire. So I think working in an enhanced space, clinicians would have developed specific knowledge and skills within their field of expertise. I think they manage a discrete aspect of patient care with deferred risk within their current level of practice. And now I think that's been beautifully demonstrated by Phil, Amy and Sam today. And in contrast to that, I think advanced practitioners will have developed a breadth of knowledge and skills to an advanced master's level, and would typically manage a whole episode of care, managing the risk and using a high level of decision making across the whole episode of care. I hope that defines it a little bit better, and it is really well described on the employer's guide for enhanced clinical practice apprenticeships on the Skills for Health website, if anyone wants to have a look at that.
And I think we will be in a position to share some of the links to these guides through the team that are presenting this careers event to you today. So we will be sharing some of those links and make them available. Thanks, Cris. So just thinking about Amy, Sam and Phil in your roles. Phil, I'm just going to ask you how you've overcome any resistance to professional blurring of roles.
I think it's a difficult one to ask, because I think every trust will be slightly different, and I'm sure Sam will have different experiences to me, so do feel free to jump in at any stage, Sam. I think one of the big things for me, as I said before, was the expectation that we're going to be taking away work from nurses, doctors, medics, etc. But I think the important thing was always being that would be a source of expertise. I think there was also some concern if that then we'd become solely responsible and it would be only dietitians placing NG tubes, which is never going to be the case with it. They are going to be needed out of hours as well for like very important medications, etc. And it's also that thing that not every dietitian does the same job. My role will be very different to Sam's role, and our roles will be very different to a bariatric dietitian. It'll be different to a geriatric dietitian. It's not the thing that one dietitian fits all. We do become specialized in our own areas. I think my top tip would be, if you can see where an area can be improved by something you think you can contribute to, don't give up on it. Do the research, do the audits, find out exactly where those systems are falling down and what can you do to do better. I know, for example, with myself, I got very frustrated at some stage, and I did start to believe that I was in the wrong profession and that dietetics wasn't the one for me, because that's just the impression I got given. I wanted to be actioning the points I was recommending rather than suggesting and going away from that. So I would just say, yeah, don't give up if you can see where you can make an improvement, and go for it and get the support of your manager. I don't know what you think, Sam.
Yeah, I absolutely agree with you, Phil. I remember when I first said to nursing staff on our ward that I was going to start doing some NG tubes, and a comment was, "Oh, they're taking that job away from us as well." I remember, so there was a couple of people that were a little bit perturbed by that idea. But I think when you really sort of communicate the reason why you're doing something to somebody, it starts to take down some of that barrier. So ultimately, I was like, I'm not taking jobs from anybody. I'm contributing to the workforce to optimize our patients' experience and treatment outcomes. It's never a case of, I want to take this from you. Likewise, I've spoken to a few speech and language therapists in the past who I think are up at night with nightmares about dietitians doing swallow screening. But ultimately, it's a competency-based framework. And if you're taught how to do it safely by somebody who can teach you how to do it safely, then it isn't a risk. And there are times where, because of staffing and because of unplanned sickness and things like that, there won't be people in certain positions to be able to do things like a swallow screen or to place an NG tube. And I know this is the pitfall of a sort of people-led service, but it's those patients shouldn't be it shouldn't be detrimental to them because because there's only a certain amount of people that can do a certain skill on the ward. It doesn't make sense to me. And I think if, as Phil said, if we kind of pitching it as we're here to contribute to the on the floor workload, but we're also here to act as a troubleshoot guide, a source of expertise. Oh, I've tried to do this, it's not worked. Even the day before yesterday, a nurse had said, oh, I'm struggling to unblock a tube, a nasogastric tube. So we're probably going to have to put a new one in. And I'm like, well, it's got a bridle and also it's a horrible thing to have to do. So have you tried this and that and the other? And then I ended up doing it and unblocking it. But then sitting down with the nurse afterwards and explaining, this is how I did it. This is the technique that I used, and this is why I find this more effective. And then they can take that then the next time and hopefully do it for themselves. It's about upskilling everyone around us. It's not about taking jobs and becoming quite sort of narcissistic and only I can do this, if you know what I mean. It's about looking at it from a team and patient perspective. And I think that those conversations, I think if anyone's struggling with sort of people not really getting on board, it's about sitting down and really having that conversation. And as Phil said, really outline the need. So there's absolutely no need in other departments, in other wards in our hospital for a dietitian to extend their role to do what I did. It'd just be doing a CPD exercise for the sake of it. And like with any specialist skill, unless you do it, you're going to forget how to do it well. And then it becomes a risk for both you and the patient. So I found having conversations, and then, I think Phil had said before, and I'm really honoured by the term pioneer, but I think it will get easier for dietitians going forward when you've got examples like myself. You've got Phil. I think there's other dietitians nationally now that place pegs and different gastrostomies, and evidence from other trusts that this does work. So we can utilise the evidence, also an apprenticeship or framework that you're suggesting with the enhanced practice, to really push on this profession and make things better for everybody, essentially.
Yeah, and I think that's the key, doing it safely and effectively as well. I mean, I had a similar experience with the NJ tube yesterday. It's been blocked all night. We haven't fed the patient. Mm-hmm. It was unblocked within a minute of walking over to the patient, and you just think, why have we lost the whole night of feed? Yeah. And again, it's feeding that back to the nurse and saying, this is what I did. This tube is now working. Let's get this guy home. Mm-hmm. And I think just to touch on what Amy said in our presentation as well, is that almost the vice versa of, we expect ourselves to, or that I forgot the word you used, Sam, of that mindset of we would then expect ourselves to do everything. That would simply never be the case. We've still got our own caseload to manage, and we've still got to make sure our patients are getting dietetic care, and that we're not just going to be running off doing all these enhanced roles because there's the opportunity to. And similar to what Amy said, if we get a call and saying, oh, this person needs a swallow screen, this person needs an NG, can you come do it? No, I've got other stuff to be doing at the moment. You will have to do it for the time being. If you can't do it, I'm happy to help or come to you once I've got my caseload sorted and my other priorities. So it's not us saying we want to control the world by any means.
Mm-hmm. Thank you. Thanks, guys. Just mindful of time, we're getting close.
Apologies.
Now. No, it's great to hear from you. It's really good to have this discussion, and I think these are the sort of things that colleagues who are on the call want to hear about, the nuances, what it's really like in practice developing in this space. I think there's probably going to be some questions in people's minds about how people fund, how individuals fund and get funding for training and development of this nature. And I just wanted to give a few thoughts from a Health Education England perspective. Obviously, the enhanced clinical practice apprenticeship that was described by Fay at the beginning of the session, that actually has a levy of £7,000 attached to it. So there's a significant amount of money invested into developing this as an opportunity for career progression. And we will share the employer guide so that with more information, so that you can see how this might benefit you as an individual. As we develop the specific professional frameworks, that will become even more relevant to you, because you'll be able to see what's available for you in your profession. And also you can have a chat through with your own employer, your line manager, in terms of why this might be an appropriate route for you to develop. And we're looking into 2023 now for those ECP apprenticeship programs to be fully sort of up and running and established as they get rolled out. HE has also got other upskilling programmes of funding available to you. Most of you, I hope, will be aware of the 3-year CPD funding that was £1,000 for each individual registered clinician, and we're just going into the 3rd year of that now, so that's still an opportunity for you this year to access funding. And then there's been a range of other opportunities around community rehabilitation, elective recovery and critical care, where Health Education England has made monies available into your systems and through your education and training departments in your organisation. So if you haven't heard about those, then we would encourage you to speak to your education and training leads in your trusts or with your allied health professions faculties in your region to find out how you can access those monies. So that's one means by which you can hopefully support yourself, develop additional competencies by and seeking some funding. So I'm going to draw things to a conclusion there. I think that's been a wonderful conversation between our colleagues on this panel today. I'd just like to thank you all for your contributions and enthusiasm, and it's just really so inspiring to hear of clinicians on the ground in our allied health professions doing such great work, pioneering, as was described, new roles in the enhanced practice space. So thanks all very much, and I hope you enjoy the rest of the conference.
Fantastic. Thank you there to everyone who contributed to that. It really is interesting to go from what we were discussing earlier, different people's careers in allied health, then discussing preceptorship and then moving on to advanced practice. I certainly learned about the difference between enhanced care and advanced care and some of the subtle differences within the allied health professions. And really getting the knowledge out there and making people aware of the different roles that exist. How did you find that, Carrie? Are there any take-home points?
So I think for me, some of the standouts for me is that we're into a transforming space. So we're starting to really understand the importance and the value of skills over role and how we all contribute different skills from our base professions that can support as a team around a patient or a team providing care. And so we need to be open and think about what's differences about we can't be protectionist over what we think is what I do and what you do when we can actually work better together. So that opportunity to upskill, to work in new ways, doesn't mean that we're no longer being a dietitian or a speech therapist or a radiographer, but it means that we can enhance our offer in that team. And we need to embrace that new ways of working. It makes it interesting, and it means that we can work to the top of our skills and abilities and use all of our knowledge and skills that best support patient care. So it's exciting, and I hope people will see that gives them a wider range potentially if they want to stay being frontline clinicians, to upskill and to really focus on how they can develop those clinical skills in different and new ways.
Yeah, absolutely. And I think it's really interesting to see the different involvement that allied health professionals have in the patient's journey, from someone like myself as a paramedic, seeing someone in the community, and then through to the emergency department where they might be working with, another allied health professional working in an enhanced or advanced role, all the way through to rehabilitation. There's people at different levels all along the way that are contributing to that. And it's fantastic to be part of that as an allied health professional.
All you do is say 1, 2, 3, and on 3 get
the traditional route that we train advanced clinical practitioners is very much from the university perspective, a master's in advanced clinical practice, which is generally driven by academic regulations. There's a dissertation.
I think there's an element of the unknown around apprenticeships. I know when I think of apprentices, I think of when I left school and people went into kind of apprenticeships from leaving school, and I never really considered a postgraduate apprenticeship as a thing that was possible.
Because that's what you examine. We've been very lucky at the University of Nottingham in that we've always been very much involved in the curriculum development, but also in the delivery. With the apprenticeship side of things, that's given us a little bit more control, and it's also allowed us as an employer and us as a system from Nottinghamshire to discuss what we would like to see within our curriculum so it meets the needs of our region. The traditional route for training an advanced clinical practitioner here at Nottingham University Hospitals is that we would apply for funding on a yearly basis, going through a process of scoping where we need ACPs. Something which I've always found very difficult is not knowing how many we will get funding for, so meaning we can't appoint to positions by the time that we will then be able to get people actually on the course. This is day one of examination. A real advantage with the ACP apprenticeship is that we pay a large amount of money into the levy, and it then means we can access that funding. So really it gives me a little bit of control about the funding every year.
Hello there.
Traditionally, people view apprentices very much from the 16 to 19-year-old category. For advanced clinical practice, the occupational standard is at master's level, and the people who are accessing the advanced clinical practice practitioner apprenticeship are very senior, experienced staff.
I work in the emergency department at the Queen's Medical Centre. My first day of actually joining the department, we were introduced to the whole team, including the advanced clinical practitioners who work there. And just hold there for me. It just something that immediately appealed to me and where I wanted to go within my career. So that's powerful. We were initially made aware of the apprenticeship through our employer, so through James, who suggested that this might be a route that would be good, particularly for the emergency department and acute medicine, because they'd already got well-established teams of advanced practitioners.
Thanks both for meeting today. This is your second tripartite?
Yeah, second. Yeah.
Cool. So I'm just going to look through your learning log for...
A real advantage of the apprenticeship is around the tripartite interviews, knowing about learning logs, knowing where our trainees are, and actually having this agreement between the university, us as the employer, and the apprentice. We have this equal agreement which allows us then to develop a ACP which suits their needs, okay, and suits our needs as an employer, and there's also good partnership with the university as well. The master's programme here is also led by a consultant, Frank Coffey.
From a University of Nottingham perspective, we very much co-produced our curriculum with the employer to make sure that what we were producing was wanted by them. In our traditional programme, we had a 60-credit dissertation and a 20-credit work-based learning module. And from an employer perspective, whilst a traditional dissertation obviously addresses the research pillar, it's quite a substantial piece of work and often isn't as beneficial for what was the traditional student. What we've switched to now is we've now got a 60-credit work-based learning portfolio. It does still address all those research aims that we would have in a traditional research dissertation and that we would need for an ACP pillar.
Obviously, as an employer, I'm keen that our advanced clinical practitioners at point of graduation are clinically competent, and we have a nice shared agreement about how that's done, how that's academically accredited, rather than having to run separate governance structures within Nottingham University Hospitals, for example. So we have a really good relationship that the portfolio work-based learning aspect of the apprenticeship programme makes up the majority of the credits, but mapped to that is not only core competencies, but we also have our specialist competencies for the individual ACPs within that area. The assessment process at the end is a joint assessment process between us as employers, the clinical leads of the ACP teams, which is often a consultant, and then Dr. Coffey would also be there as well, representing the university to ensure that the competence of our advanced clinical practitioners is at the level we want at point of graduation. So we're going to do it in the thumbs.
We are 6-7 months now into the apprenticeship. And it's been a good experience. It's allowed a much closer relationship for the employer, the student, and the university to kind of all collaborate together. It is a challenge, and there's no kind of getting around that. There needs to be hard work put in, both within the clinical environment of your day-to-day work and also academically as well.
The biggest advice I would give other institutions considering this is really look at the detail once your programme's written and look at how you manage the process of the initial needs assessment and managing the learning logs and the tripartite reviews.
Let's just say normal reflexes. You could say with it, if you want to say spinal root, C7, C8. For me, it would seem that this is the appropriate use of our levy is to actually access that more for our advanced clinical practitioner trainees for next year, and actually say as a cohort, as long as the specialities can support the curriculum, we would take the majority, if not all of them, on an advanced clinical practitioner apprenticeship pathway.